Okay, start. Anju, start. Yes.
Okay, thank you, sir. Recording, sir. Recording mode, live mode. Okay, Anlo.
Yes, yes. Okay, fine.
Okay, thank you. Hi, very good evening to all. Welcome to another session of Journal Club of IAP Thiruvananthapuram. Today, we are having a very interesting session from pediatric cardiology. And we have eminent pediatric cardiologists from SAT Hospital Department of Pediatric Cardiology with us. We have Dr. Lakshmi, Head of the Department, Pediatric Cardiology, and Dr. Harikrishnan KN, Sir is Assistant Professor, Pediatric Cardiology, SATH. A novel drug, as far as pediatrics is concerned, will be dealt with in today's paper. It will be presented by Dr. Gautham Vishwanath and analyzed by Dr. Meena PK. As the panelists in the expert panel, we have Dr. Ramankutty sir and Dr. Padmanabhan sir. So without losing much time, I would like to go to the session proper. And since the expert panelists have other meetings also to attend, I would like to request the presenters and the analysts to keep it as short as possible and precise. But there is no need to hurry also. Over to Dr. Srijit Kumar sir, Secretary, IAP Thiruvananthapuram.
Nothing more. Just to congratulate Dr. Anju Kanmani for organizing this program. And also, we are fortunate to have our pediatric cardiology team. We are just concluded our World Heart program last day with a very more than 1,000 children attending our SAT hospital program. So we are happy to have Dr. Harikrishnan and Dr. Lakshmi Madam here in our program, and we are happy. We are looking forward to for a wonderful academic session. Over to you, Anju. Thank you.
Shall we start, Dr. Padmanabhan sir? Any opening comments, sir?
You're mute.
Sir. Sir was mute, sir.
Mute. Okay. Carry on,
okay,
please.
Okay. Yes, sir. With the Lakshmi Madam's permission and Dr. Harikrishnan's permission, we would like to start the session. But before that, regarding the foundation, I mean, to set the background of this discussion, I would like to request Dr. Harikrishnan sir to give a few words on the topic. Over to Dr. Harikrishnan sir.
Thank you. Thank you for the kind introduction. Going to the topic proper, the journal as such, we have chosen a journal, chosen a particular article where they've done a randomized controlled trial, which is extremely rare in the pediatric population to have a randomized controlled trial due to the obvious limitations in the pediatric population. So why we have chosen this journal? One is because it is a randomized controlled trial and it is on a novel drug as far as pediatrics is concerned. It is a novel drug which has had extensive studies in the adult population, and it has been proven to benefit adult heart failure. So this study is basically on pediatric heart failure. As we know, we have very, very few drugs in pediatric cardiology and pediatric heart failure. So this drug, we'll discuss how it was studied, why as to the rationale behind using this drug, why it was studied, and have we found any benefit or not. So although the study is, its primary objective was to demonstrate superiority over the commonly used AC inhibitor, it is not a positive study, it's a negative study, but since it is it is a randomized controlled trial and it is on this novel drug, we'll discuss as to why they did not prove to be beneficial over the commonly used drug, that is enalapril. And as you all know, there are very few drugs. So what are the pillars of heart failure management? In adults, it is already established that beta blockers, AC inhibitors, or this new class, that is angiotensin receptor neprilysin inhibition, ARNI, that would be the second class. Third class would be mineralocorticoid receptor antagonists like aldactone, spironolactone. And the fourth class of drug is dapagliflozin. So these are the four pillars of heart failure management in adult heart failure. In children also, we have very few small trials where carbidopa as a beta blocker has been proven to be beneficial. And all the other drugs that we use are basically all the other drugs that we use are basically derived from adult data. So in children also, we commonly use ACE inhibitors, uh, uh, this carvedilol or any other beta blocker, and aldactone along with diuretics. But dapagliflozin, only some recent studies are there. And ARNI, this is the first large-scale randomized control trial. So over to Dr. Gautham for his presentation.
Thank you for that introduction, sir. Over to Dr. Gautham Vishwanath for the presentation. You can start sharing the PPT, sir.
Is the screen visible, sir?
Yes, can you make it full screen, Dr. Gautham? Yeah, it is visible. You can continue, sir. Okay.
Okay. So good evening, sirs. My name is Gautham Vishwanath. I am a junior resident in the Department of Pediatrics, SCT Hospital. So I'll be presenting this journal today, which will later be analyzed by Dr. Meena. So the title of the study is Panorama HF, Study of Sacubitril Valsartan in Pediatric Heart Failure. And as mentioned, it is a randomized multi-center double-blinded trial. So talking about the background of the study, pediatric heart failure in children is the common sequelae of cardiomyopathy and congenital heart disease. But this in pediatric population, it is associated with a high level of morbidity and mortality. This causes frequent hospitalizations and it also decreases the quality of life. The main issue is that there are only very few randomized trials that help us to build therapeutic guidelines on the management of pediatric heart failure. And the main causes for this are the heterogeneity in pathogenesis of the disease and the lower prevalence rates of the disease compared to the adult population. Sacubitril valsartan, the drug is an angiotensin receptor neprilysin inhibitor, and it has shown significant benefits in mortality and morbidity in the adult population in patients with heart failure with reduced ejection fraction when compared to enalapril. It is also approved by the US FDA for use in cardiovascular death and hospitalization in adult patients. It is also recommended by the European Society of Cardiology and the AHA guidelines, and it is preferred over ACE inhibitors for adults. However, the benefits of ARNI over ACE inhibitors are not studied in children. So the main purpose of this study is to assess whether pediatric children, specifically in the age group 1 month to 18 years, will have a greater clinical benefit from using ARNI over ACE inhibitors. So coming to the study design, this is a two-phase study which was done in 30 countries over 105 sites. The phase 1 is an open label single dose pharmacokinetic and pharmacodynamic study. This was mainly done to determine the dose of the drug. And phase 2 is the 52-week randomized double-blinded parallel clinical efficacy study. So this is the global rank endpoint which they have used to assess the clinical response of the drug in the patients. This mainly has 5 categories. Category 1 is either death or need for a heart transplant or equivalent, or need for a ECMO or mechanical ventilation or aortic balloon pump requirement. Category 2 is worsening of the heart failure. Category 3 is worsening of the NIHA-ROS classification of the PGIS score, Patient Global Intensity of Severity score. Category 4 is an unchanged NIHA-ROS classification or PGIS score. And category 5 is an improvement in the NIHA-ROS or PGIS score. So this is the basic categorization they have used to assess the response of the drug. Study population. The inclusion criteria are children falling in the age group of 1 month to 18 years of age with heart failure, having a biventricular physiology with systemic left ventricular systolic dysfunction. And the patient should have a left ventricular ejection fraction which is less than 45% or a fractional shortening less than 22.5%. So correspondingly, the exclusion criteria would be children with a single ventricle physiology and conditions like tricuspid atresia, or a systemic morphological right ventricle, a restrictive cardiomyopathy or hypertrophic cardiomyopathy. Children with such conditions were excluded from the study. And the children were grouped into 3 groups. Group 1 are children falling into the age group 6 to 18 years. Group 2, 1 to 6 years of age. And within the group, they have modified into a group 2A, which is children of the age 2 to 6 years of age. And then there is group 3, 1 month to 1 year of age. Within the group, there is a subgroup, group 3A, which was modified to have children from 1 month to 2 years of age for ease of the study. This new classification was done so that they can have better results in children of a particular age group, less than 2 years of age. Dosing of the study. This dosing was acquired from the phase 1 of the study, which was discussed earlier. And according to the results of the phase 1, the dose was fixed at 3.1 mg per kg BD for groups 1 and 2, that are the older children, and 2.3 mg per kg BD for group 3. The primary objective of the study is basically to determine whether sacubitril valsartan is superior to enalapril for the treatment of heart failure with reduced ejection fraction. And the secondary objectives include finding the time to first occurrence of a category 1 or 2 event as described earlier, any change in the NIHA or ROS status of the patient, any change from the baseline NT-proBNP levels, and to see if there is any change in the pediatric quality of life or the patient global impression of change scoring over a period of 52 weeks. Now, coming to the baseline disease and demography of the study population.
Gautham,
This table, yes, sir.
Can you just go back to the slide? So how have they defined heart failure with reduced ejection fraction?
Sir, they have put a cutoff of a left ventricular ejection fraction of 45%, sir, according to the study.
So less than 45%.
Less than 45% is what they've taken as the cutoff for the study.
Okay, okay.
So in this table, we can see the pathologies that are associated with heart failure. The distribution of pathologies is almost similar between the two treatment arms. And out of all the pathologies, we can see that cardiomyopathy stands to be the most common. And within cardiomyopathy, idiopathic is the most common cause of heart failure in children. And on the second table, we can see the NIHA-ROS classification. And out of this, more than 80% of the children come under the NIHA 2 classification or higher. And the study also observed that more than 80% of the study population had an LVF, which is less than 40%. This table shows the drugs that the children have already been taking before starting the study. And we can see that almost 80% in both, 88% in both treatment arms are already on ACE inhibitors. And 81% are already on MRAs. 39% to 34% are already on digoxin. And a considerable 50% of children on both arms are already on antithrombotic agents. So moving on to the results and discussion of the results. So this table shows that there is no statistically significant difference between the two treatment arms when taking the global rank endpoint into consideration. Both the treatment arms have showed a similar improvement according to the global rank endpoint. The confidence interval falls between 0.72 to 1.14 and the p-value is 0.42. Taking the NIHA-ROS classification, there was also no statistically significant improvement in the NIHA-ROS functional status between the two treatment arms. Confidence interval 0.7 to 1.7 and p-ratio is 0.76. There was an increase in the number of patients in the NIHA class 1, which is 13.4% to 48.5% in the ARNI arm and 18.1% to 47.5% in the ACE inhibitor arm, showing similar improvement in both arms. Now, talking about the PGIS score or the patient global impression of severity score, there was no statistically significant change between the two arms with a confidence interval of 0.7 to 1.8 and a p-ratio of 0.54. However, when we come to the pediatric and patient and parent reported quality of life score, there was a statistically significant improvement that was noted in the sacubitril valsartan arm when compared to the enalapril arm. The cutoff they had kept for an improvement in quality of life was 4.5, and this was crossed only in the group that had taken sacubitril valsartan. So this shows a better health-related quality of life improvement in patients who are on sacubitril valsartan. Coming to the NT-proBNP levels, the levels were taken at week 4, week 12, and week 52. So when we look at the levels in week 4, the levels decreased more with the sacubitril valsartan arm compared to enalapril with a confidence interval of 0.61 to 0.87 and a p-ratio of 0.001. However, when the study progressed to week 12 and week 52, the reductions were similar in both treatment arms with the p-ratios of 0.32 and 0.5 respectively, showing that the efficacy of both the drugs were same at week 12 and week 52. The reduction in NT-proBNP levels were faster with sacubitril valsartan in week 4. However, at the end of the entire study, the differences were similar. Now coming to the safety profile of the drug, the statement they have said that the risk of serious adverse effects of the drug in children was similar to the safety profile that was found in adults and no new safety concerns were found. And this table shows the most clinically relevant side effects that were found with the drug, which includes hypertension, hyperkalemia, and cough. This is another table that shows the total incidence percentage of any adverse effects, serious adverse effects, and overall death in the study. And a total of 88% of patients in both treatment arms have observed one kind of adverse effect or the other, out of which 36 to 33% were serious adverse effects. One note to be pointed is that the death that is mentioned in the study is not due to the drugs alone. It is an overall death, including the disease pathology also. So we cannot attribute it just to the use of the drug.
How have they defined serious adverse effects?
Sir, requiring hospitalization, I think. So I did not find a clear definition for serious adverse effects.
I think whatever you showed, no? Hypotension.
Yeah, these are the most clinically relevant serious adverse effects. Hypertension, hyperkalemia, and cough. Coming to the limitations of the study, the main limitation is that the incidence of heart failure in children is very low compared to that of adults. And there are no defined validated endpoints when it comes to pediatric heart failure. Death and heart failure hospitalization was not feasible due to the lack of the number of patients. And then there was a huge difficulty in gathering patients from younger age groups, especially age less than 1 year. These are the main limitations of the study. So concluding the entire study, Panorama Heart Failure is the largest randomized double-blinded clinical trial in pediatric heart failure ever to be performed. No significant differences were seen in the global rank primary endpoint between the two treatment arms. There is evidence of a possible health-related quality of life advantage of the sacubitril valsartan arm over enalapril arm. The safety profile of the RNA drug is acceptable in children and is comparable with enalapril. So, sacubitril valsartan has demonstrated a favorable benefit to risk ratio in treatment of heart failure in pediatric patients of age group 1 to 18 years over a period of 52 weeks. Thank you.
Okay, thank you, Dr. Gautham. From what Gautham has been presenting, one would get the impression that since there is no difference, why don't we try this valsartan also, except for the serious adverse effects and all. And this parent reported, certain advantages are also there. Well, it is too early to comment. Let us go to the analysis by Dr. Meena PK. Dr. Meena PK. You can start the screen sharing, madam. Yes, the slides are visible. You can start the presentation. Is your audio okay? Are you muted, madam?
Is it audible, sir?
Yeah, it is audible, madam. Please continue.
I'm Dr. Meena, junior resident of SAB Hospital. So I.
Sorry, madam. Can you please the mic a little closer? Can you be louder and a little closer to the microphone? Thank you. Please continue, madam.
Sir.
Yeah. Yes. Please continue. Sorry for this technological issues. Dr. Meena, is it fine now? The slides are visible.
Okay, now.
Yeah, you can continue, no problem. Yeah.
Okay. I am studying satellite period and at the pandemic, double blind.
You are not audible.
Dr. Meena, madam, can you? Yeah, there is some issue with the audio. Can you keep the microphone a bit closer to your mouth and be a bit more louder?
Yeah, okay. Hello?
I think there's an issue with the.
Yeah.
Hello?
I think it's an issue with the internet connection.
Yeah, I think it's a connectivity issue.
Yes, yes. Can you please continue presentation, whether we can see whether it is getting better or not, or?
Yeah.
Meena?
Dr. Gautham? Is Dr. Gautham there?
Yes, sir, I can hear.
Dr. Gautham, do you have the PPT of Dr. Meena?
No, sir, I don't have it with me.
Okay. Dr. Meena can send the PPT to Dr. Gautham in WhatsApp, and Meena, madam can enter in the phone if you want, if the laptop is not good. Or you can switch on the laptop, move the slides, and talk through your phone also, keeping the lap mute.
Or Dr. Meena can send it to Dr.Anju or something.
Yes, sir. Yeah. Dr.
Of
Meena,
course, your problem will not be
can you
solved.
talk? Okay. Yeah, yes, sir. Can you start talking once more?
Is it audible now?
Yeah, can you start talking? Yeah.
Audible but not visible.
Okay, Dr. Meena, can you do one thing? Hello, Dr. Meena?
Yes, sir.
Yeah. Dr. Gautham, are you having WhatsApp in your laptop?
Yes, sir, I have it. I can take it if she sends.
Dr. Meena, can you send the PPT to Dr. Gautham?
Yes.
Yeah. Please inform us after sending, okay? Apology for this, and I would like to request everybody to at least use a few minutes, 2 or 3 minutes.
Any comments from the mentor regarding the initial presentation, Dr. Harikrishnan? Meanwhile,
So
Yes,
we had
I was
planned
asking
it.
questions and
We had planned it to keep the discussion during the analysis. So that's why I did not speak much. So we'll be discussing individual components of whatever was shown, like even the inclusion, exclusion, the statistical analysis, and it is the analysis is done, based on the consort that statement. So that we'll discuss anyway. I mean, while it is being sorted out, Ramankutty sir, can you just discuss what's the difference between a superiority versus equivalence or non-inferiority trial?
Yeah, I mean, but before that, I just want to ask you, why did you speak of a p-value as a ratio?
Yes.
Is it given in some textbook or something? P-value is a probability, goes from 0 to 1.
What
You
value,
said
sir?
P ratio. You kept saying P ratio. I don't know why. I mean, I don't know if there is some textbook which calls it a P ratio, but I haven't seen that terminology anywhere. It's a p-value. It's not a ratio. I mean,
Okay, sir. Okay,
p-value
sir.
can be called a ratio because
Okay.
you can, any rational number is a ratio. In that sense, mathematically, maybe it's a ratio. But usually you don't call it a ratio. Anyway, I'm not saying it's a big mistake or anything, but is it from some reference that you get it? I don't know. Otherwise, of course,
I think the people.
yeah, it is a.
Please continue, sir. Please continue.
No, what I wanted to say is I'll repeat it afterwards also. This is actually showing that it is equivalent rather than not inferior, so to speak. Usually such trials or such results are not, we always say that negative results are not published, but here I think because of the importance of this drug, maybe that is why they have published it. But one thing I wanted to know was, did they really did you look at the journal article? Did they calculate the sample size properly? Is there any description of that? Because I don't remember reading that.
It is not mentioned. How they've calculated samples is not mentioned, although written it is 370.
Yeah.
They've not mentioned.
So as you say, you also rightly pointed out that getting children with heart failure is very difficult. So they might have done the trial with whoever is available. And it could be that it is because the numbers are low that it didn't get a p-value, I mean significant p-value. But it also means that actually the actual difference may not be much. So their conclusion, I'm not contesting their conclusion, which seems to be okay, but that is all I will say at this point.
Sorry to interfere in between, sir. Dr. Meena, if everything fine? Hello, Dr. Meena?
Hello, sir. Hello.
You can continue, madam.
Yeah.
Can you, one second, Dr. Ramankutty, sir, can we continue the presentation? Dr.
Yeah,
Harikrishnan, sir?
sure.
Please continue, please. Yes, sir. Please continue.
And change the.
Dr. Meena, are you listening? Hello, Dr. Meena? Dr. Meena? Are you listening?
Yes, sir. Yes.
The audio is still having some issues. Can you stop screen sharing? Let Gautham screen share. You can just go to a place where you can get good connection and you can enter through the phone. You can click the link in the WhatsApp and can enter the session and start presenting. Dr. Gautham will help you with the PPT. Is it okay?
Sure. Okay, sir.
Okay, thank you. Okay, thank you. You can now, yeah.
So this screen which is shared is by Meena or by Gautham?
Yeah, Dr. Gautham has now shared the screen. Am I right, Dr. Gautham?
Yes, sir. This is from my system.
Okay.
Fine. I think Meena madam should log out and then enter, right? Or it is possible from like this only, right? She can enter from another device also. It is okay, no? Okay. Can you talk speaking, madam? Could you speak anything so that we could hear you?
Sir. Are you able to hear me now?
Have you entered from another phone? Another device? Gautham, I think Meena Madam has got my message, right?
Gautham, actually, you can help. Can you help present this session also?
Yeah, that is another option actually.
Yeah, just we all help. I think that will be the solution right now. Can you change the slide?
Yeah.
And just
Yes, sir.
present?
Is it audible now, sir?
Yeah, it is audible. You can, Srijit sir, I think Meena Madam has entered from another phone and she is audible right now. So shall we continue?
Yes.
Yeah, okay. You can start continue. And Dr. Gautham, kindly help her. Okay,
Okay.
go forward, ma'am.
Okay, sir. So I will.
Yeah, one more thing, Dr. Meena. Can you please log out from the laptop? Otherwise, you will have echo.
Yeah, it is now clear. Is it now clear, sir?
Yeah, no, fine. Okay, fine.
Okay, sir. So, so I'll be presenting on the analysis of our journal. So, our title was Sacubital Valsartan in Pediatric Heart Failure, Panorama Heart Failure, a randomized multicentric double-blind trial. Next slide. Dr. Gautham, can you change the slides? Yeah, so coming to the critical analysis, the study is a randomized controls trial, and we'll be analyzing the study based on consort statement, the consolidated standards of reporting trials. Next slide, please. So this is the hierarchy of scientific evidence where RCT is one of the superior most type of studies. Next slide. Then we will be analyzing the study based on the consort statement. And next slide. This shows the consort 2025 checklist item description for the randomized control trial type of studies. And it comes under 30 subheadings, and which will be discussed one by one in our discussion now. So first title is title and abstract of the study. Among that, the first point is identification as a randomized trial. Yes, Gautham, can you please change the slide? For the title and abstract, the study itself identified it as a randomized multicentric double-blind trial. Yeah, so that criteria has been fulfilled. Next is the abstract. Coming to the abstract, it contains a structured summary of trial design, methods, results, and conclusion. A clear summary has been explained in the abstract. Next one, coming to the open science, next title, about the trial registration. Name of the trial registry with identification number and URL has been clearly mentioned. And coming to the protocol and statistical analysis plan, the abstract does not explicitly show a direct link to full protocol, but the statistical analysis plan was given in detail as a supplemental material. The statistical analysis will be discussed later in the discussion. And coming to the data sharing, about the data sharing, Novartis company was committed to sharing access to patient-level data, and all data provided were anonymized to respect the privacy of patients who have participated in the trial in line with applicable laws and regulations. And about the funding and conflicts of interest, the abstract shows significant Novartis involvement among other authors, which suggests industry sponsorship in the study. Next is the introduction. Coming to the introduction,
so that is a potential source of bias because Novartis is the company which is
Novartis was
giving the drug, and many of the authors have disclosed contacts with Novartis, right? Although they have reported, it is a source of potential bias.
Yes. And coming to the introduction part, about the background and rationale. A scientific background and rationale have been clearly reported. that is, the sacubitril valsartan has demonstrated actually a significant clinically important mortality and morbidity benefits in adult patients with chronic heart failure or reduced left ventricular ejection fraction compared to enalapril. This is what studies showed in adult patients. But because of the heterogeneity of pathogenesis and low prevalence of pediatric heart failure compared to adult heart failure, there is a lack of well-powered randomized trials in pediatric population. So the study will help in recommendations to be relied on for further treatments in pediatric heart failure. And coming to the objective.
Can you discuss the rationale also, Meena?
Sorry, sir?
Can you discuss the rationale for this new drug in heart failure?
Yes, sir. Actually, sacubitril valsartan or ARNI, it's a combination of two drugs, sacubitril and valsartan. And sacubitril, which is a neprilysin inhibitor, will increase the levels of natriuretic peptides, and which causes natriuresis and diuresis, along with valsartan, which is an angiotensin receptor blocker. So, actually, in adult patients, the ARNI has shown a significant increase or increase in the benefits in terms of mortality and morbidity. But in a pediatric population, due to the lesser number of sample size and difference in pathogenesis, studies have not been conducted in pediatric population with this drug. So this is a new study based on to show whether there is any advantage of using ARNI over enalapril in pediatric heart failure population.
Apology to Harikrishnan, sir. I would also like to ask one more doubt here. What is neprilysin, madam? Can you throw a little light on that?
Yeah, sure, sir. Yes, sir. Neprilysin is an agent which causes lysis of natriuretic peptides.
Okay.
Which so by blocking neprilysin, neprilysin is basically an enzyme that breaks down natriuretic peptides and bradykinin. So by blocking neprilysin, these natriuretic peptides will be levels will be increased, which causes natriuresis and diuresis and vasodilation. These are vasoactive agents, and so that afterload will be reduced.
Yeah. Was sir's question answered? I was just asking Harikrishnan, sir.
Yeah. So what I meant is for the others who are listening, so basically AC inhibitors have a documented role. They have a vasodilatory role, and they are important in preventing fibrosis of the heart and in positive remodeling of the heart. So along with that, we needed drug for which inhibits natriuretic peptide degeneration to increase the natriuretic peptide level. So they cause natriuresis, diuresis, and vasodilatation. So that is why this combination was thought of.
The rationale was that
ARBs, which are angiotensin receptor blocker, that is valsartan, along with an neprilysin inhibition.
Okay. Thank you, sir. Can we continue, sir? Yeah, please continue.
Yes, sir. Coming to the objectives, specific objectives related to benefits and harms have been clearly mentioned in the study, which was already explained by Dr. Gautham in the previous presentation. And coming to the methods, patient and public involvement. Details of patient and public involvement in the design, conduct, and the reporting of the trial is not addressed in the abstract. And coming to the trial design, description of the trial design was reported. It is a parallel group study with 1:1 allocation ratio, and it is a superiority trial. Then changes to the trial protocol. important changes to the trial protocol was mentioned clearly. And the main change occurred during the study was a change in the group of sample. So initially it was the 3 groups were there, group 1, 2, and 3. But because the recruitment was done according to the age, the older patients were recruited initially, then the younger patients were recruited, and less number of patients in younger age group. Because of these 2 reasons, the groups were actually modified. Group 1 remained unchanged, that was 6 years to 18 years, but group 2 and 3 were modified to group 2A and 3A. 2A now became 2 to less than 6 years of age, and 3A became 1 month to less than 2 years of age. Actually, this modification actually enabled a more robust analysis of the safety and efficacy of the data for children less than 2 years of age. Otherwise, if the previous groups were used, the number of patients in younger age groups will be very much less, and that would have been affected the results also. And next is the trial setting. The settings and locations included 30 countries and 105 sites across Europe, America, Asia, and Africa. So it was a multinational, multi-centric study, and the sample size actually studied as actually 375 patients across 105 sites. So the chances of an unequal distribution of cases among the sites is a possibility in this case. Then coming to the eligibility criteria. Eligibility criteria for participants was clearly mentioned according to the age group and the LV systolic dysfunction or LV ejection fraction. Age group studied was 1 month to less than 18 years of age, and which was divided into group 1, 2A, and 3A, which was mentioned earlier. And LV ejection fraction was taken as a cutoff of 45%, which was actually not specifically, there is no specific cutoff of as 45% in pediatric heart failure classification according to the ejection fraction. And also it has been mentioned that a group of pediatric patients which has ejection fraction similar to heart failure with reduced ejection fraction in adults have been taken for the study. It was mentioned like that in the study. So I think that is why they may have kept 45% as the cutoff for LV ejection fraction. In adults, less than 41% was the cutoff for heart failure with reduced ejection fraction. Then coming.
So just clarifying that, what you mean is the normal ejection fraction in children are slightly higher than that in adults. That is what you mean, right? Children, normal ejection fraction, if you take this percentage, it will be more than 65%, whereas in adults, we normally take more than 60% as the normal ejection fraction. And in adults, there is a classification wherein they classified as heart failure with reduced ejection fraction, preserved ejection fraction, and mildly reduced or mid-range ejection fraction. So there it is less than 35, 35 to 40, 40 to 50, and more than 50. So I mean, it is like that. So if you take the normal ejection fraction of a child is 65%, and the normal ejection fraction of an adult is 60%. That is why probably they have taken 45% and not 40% in children.
Yes.
That is what you meant, right?
Yes, sir. Then coming to the intervention and comparator,
and this exclusions also.
Yeah, exclusions were also there. That was single ventricular physiology, which include tricuspid atresia, hypoplastic left ventricle, hypoplastic right ventricle, and systemic morphology of right ventricle, which actually included corrected TGA by atrial switch or congenitally corrected TGA, and restrictive cardiomyopathy and hypertrophic cardiomyopathy. Actually, these were excluded because in restrictive cardiomyopathy and hypertrophic cardiomyopathy, the left ventricular function below 40% is not expected. Actually, restrictive cardiomyopathy, both of these are diseases of problem with dilatation of the heart rather than systolic function. So these were excluded.
Problems of diastolic dysfunction, not dilatation. It is
sorry, diastolic dysfunction
rather than systolic dysfunction.
Yes, sir.
And single ventricle physiology and in morphological right ventricle, you expect EF to be lower than normal. So that is probably the reason that they excluded these cases.
Okay. Okay.
Okay, go ahead.
Coming to the intervention and comparator. Intervention and comparator with sufficient details have been mentioned. Interventions include sacubital valsartan to arm and enalapril treatment arm. And the target dose for sacubital valsartan was decided according to the part 1 of the study, which was an open label single dose pharmacokinetic and pharmacodynamic study. According to that, target dose was decided for each group. Group 3, which was the younger age group, had a target dose of 2.3 mg per kg, and group 1 and 2 target dose was 3.1 mg per kg BD. And this ARNI was available in capsules of 50 mg, 100 mg formulations. Then coming to the outcomes, pre-specified primary and secondary outcomes, including the specific measurements, were clearly reported. The endpoints were assessed using a primary global rank endpoint through a 52 weeks of treatment duration. And in addition to that, NT-proBNP change was also listed as an exploratory outcome. So this was the primary global rank endpoint from worst to best, which was already explained by Dr. Gautham. It was divided into 5 categories from 1 to 5. That was from worst to best outcomes. Then coming to the harms and serious side effects were described for each treatment arm. The incidence of serious, it was noted that the incidence of serious adverse effects were actually comparable between the 2 treatment arms, around 36 and 33%. And the incidence of overall side effects were also comparable among the 2 treatment arms, coming to around 88 to 87%. Then coming to the sample size. The sample size calculation as such was not shown, but the abstract lists the randomized N equal to 375 as the sample size. And the explanation for any interim analysis or stopping illness, nothing was reported clearly in the study about these events. And coming to the randomization, first one is the sequence generation. It was clearly mentioned that all eligible patients were actually randomized through an IRT, interactive response technology, to one of the treatment arms. Actually, it was a stratified randomization, stratified according to the age group 1, 2, and 3, and also according to the NIHA classification, class 1 or 2, and class 3 and 4. So from each age group, there was 1:1 allocation of the patients with a random block size of 6. That is, from each age group 1, there will be a patient from class 1 and 1 or 2 of NIHA, and a patient from class 3 or 4 of NIHA. So from each age group, similar patients were recruited for the study. So that consists of a random block size of 6. And coming to the patient allocation concealment mechanism, which was clearly mentioned. Initially, there was a patient number, and from that patient number, and randomization list random number was allocated to each patient, and the randomization list was prepared by the IRT, and that random number for each patient will lead to a treatment arm, either sacubitril, valsartan, or enalapril, and that will lead to a medication number, and that medication number actually leads to a pack containing the experimental drug. So each arm, each medication, and each patient was randomized with a particular number. So allocation concealment was actually maintained well. Coming
Sorry
to
to interrupt, Dr. Meena, can be a bit faster because we are already out of time.
Yeah, sure, sir.
So
Sure,
can
sir.
you just...
Yeah, sure, sir. So coming to the implementation, neither the personnel neither the personnel who enrolled and nor who assigned were had no access to the random allocation sequence, and blinding was actually maintained. It was a double-blind study. And coming to the statistical method, to compare the groups were based on Mann-Whitney probability and Mann-Whitney odds, but there was no multiplicity adjustment for secondary or exploratory variables. Coming to the methods, next one is the inclusion criteria, which has already been defined according to the age group and left ventricular ejection fraction. And how missing data was actually handled is that for association between NT-proBNP and the risk of category 1 or 2 events, missing NT-proBNP level baseline levels was actually imputed using mean value within each treatment arm, and almost comparable number of patients were actually missed baseline NT-proBNP levels from each treatment arm. 8 from a ARNI arm and 6 patients from enalapril arm were actually missing the baseline NT-proBNP levels. Then coming to the participant flow, including flow diagram, which was reported clearly in the next slide. Actually, the next slide shows a flow diagram among which the almost 420 patients were screened for the study, among which 377 were randomized. Misrandomized were 2, and full analysis set included 375 patients, among which 187 patients received ARNI and 188 received enalapril, and those who completed the study were almost equal, 169 in ARNI arm and 164 in enalapril arm. And coming to the results, dates and in that recruitment, dates defining the periods of recruitment and follow-up were actually not mentioned clearly in the abstract. And coming to the intervention and comparative delivery, intervention and comparative delivery as they were actually administered was actually clearly mentioned, and any concomitant care received during the trial was not clearly mentioned.
Dr. Meena, you can just mention the relevant points, or can a bit rush through, madam? Okay. No need to, for the rest of the slides. Just mention the important points.
Okay,
madam,
sure,
thanks.
sir. Coming to the baseline data, a table showing baseline data were given for each group. Among that, one to be discussed is the previous cardiovascular medication. Most of the patients received ACE inhibitors, which is the most commonly used drug for pediatric heart failure. Apart from that, beta blockers and diuretics were also there. And one of the things to be noticed is that 50%, almost 50% of the patients from each treatment arm were on antithrombotic agents, which is actually not a common drug used in pediatric heart failure unless it is actually used for severe heart failure cases. That is when ejection fraction is almost less than 35%. And coming to next one to be discussed is the previous heart failure.
I think this slide was discussed, madam. Anything to add on, or extra from Dr. Gautham was point? Anything to add? Because this was already discussed, I think.
The thing to be discussed is that, sir, cardiomyopathy was the most common primary heart failure pathogenesis, and among that, it was idiopathic, almost 60%. And that is what we see in our pediatric population also. So that generalizability to our pediatric population is actually work. Then coming to the results, Number analyzed, outcomes and estimation were clearly mentioned. This was the previous, next slide shows the previous flow diagram. And also this coming to the global rank endpoint, that was the primary outcome of our study.
Next slide.
Then these were the secondary objectives: time to first positivity of to category 1 or 2 events. Actually, the confidence interval and p-values were statistically non-significant. For pediatric quality of life summary also, the statistical significance is questionable. Then this is a PGIS, which was also studied. According to the age group, severity of heart failure was studied. And for global rank primary endpoint, any one class change in PGIS was considered a significant change. Next slide shows the PGIS score. It was studied at 4 weeks and at the end of 52 weeks. Most of them showed better or no change with both the treatment arms. And much worse was not seen in any of the patients. Coming to the harms, all harms and unintended events in each group were clearly mentioned. Most of the adverse events were actually non-serious in both arms. About 20% showing pyrexia and URI in sacubital valsartan arm, and 21 showing only vomiting in enalateral arm. Coming to the, this has already been discussed, clinically relevant serious adverse events.
Yes, this was discussed, no issues.
Yes, sir. Yes.
Yeah, you can go to the next slide, no issues.
Yes, sir. So this was the table showing any adverse events which was already discussed, and discontinuation due to adverse events were actually shown in both arms equally. 11.2% of the population were discontinued due to adverse events from the study. And coming to the ancillary analysis, other analysis performed were NT-proBNP trend from the baseline and association between NT-proBNP levels and risk for category 1 and 2. The next slide shows the trend in NT-proBNP levels, which shows a fall in NT-proBNP levels is more pronounced in sacubital valsartan arm at week 4. That is, NT-proBNP is a marker for heart failure control. So immediate control of heart failure is more with ARNI rather than enalapril. But coming to, as the period progresses, coming to the week 52, the results were actually comparable. The trend were actually comparable in both arms. So conclusion is that immediate control of heart failure is more prominent in ARNIs. Then coming to the discussion part. Next slide.
Madam, in the analysis part, only the only the results are already been discussed, madam. Just the analysis part only need to be mentioned, madam.
Yes.
Kindly go on, madam. Yes, madam.
Yes, yes. So coming to the discussion, interpretation consistent with results were actually consistent with the results and of balancing benefits and harms, and the results have already been discussed by Dr. Gautham. There was no significant improvement in NIHA score or PGIS score, and which were actually comparable in both treatment arms. Next slide. And throughout the panorama heart failure study, NT-proBNP levels were substantially decreasing compared to the baseline in both treatment arms, and it was also comparable. Coming to the limitations, trial limitations were addressed, and which include low incidence of heart failure in children and no validated endpoints in pediatric heart failure, and death and heart failure hospitalization as primary endpoints in pediatric heart failure trials are not feasible because of the difficulty of enrolling sufficient number of pediatric population. Then, and also the fixed duration of 52 weeks further reduced the probability of cardiac events. Another limitation was the difficulty in accumulating enough trial data in the youngest patients, which ultimately lead to the modification of age groups also. And list of Indian hospitals participating in the study has not been clearly mentioned. So generalizability to our population, Indian population, is also questionable. Then coming to the conclusion, Panorama Heart Failure is the largest randomized double-blind pediatric heart failure clinical trial to date. And overall, actually, this RCT adhered well to the consort checklist. The study included a relatively homogeneous pediatric heart failure population with pathophysiology similar to adults with reduced ejection fraction heart failure, and mostly attributable to dilated cardiomyopathy. And minor limitations were addressed, but despite this, the study is actually methodologically sound. That's
yes, madam. Continue.
Actually, the results were in contrast to the findings from Paradigm heart failure study in adults, which showed a superiority of ARNIs over enalapril in adult population. In our study, it was actually comparable in pediatric population, the results.
Any comments, madam? I mean, do you have any theories for that? Like, would you like to comment that it could be due to some problem in the physiology of which
yes,
is essential difference in the physiology or in the research
difference
methodology?
In
Yes, ma'am.
Difference in pathogenesis of pediatric heart failure is what we found for the difference.
Thank you, madam. Okay. I think Dr. Ramankutty sir and Dr. Patnam sir both have to leave faster because they have other meetings also. So without losing time, Patnam sir, just 1 second, sir. We will let you leave in a few minutes, sir. Over to Dr. Ramankutty sir.
Thank you.
Stop sharing, please, sir. Okay,
yeah,
thank you, madam.
Since I have to leave presently, I will just make it very short. First of all, it's a very interesting study, and it's well written up. I am not commenting on the contents because I'm not competent to do that. It's well written, and they have looked at all the details. As you presented, the consort guidelines have been kept very well, so that is good. From the design point of view, there are two interesting aspects to the study. One is that it is a negative study in the sense, in a clinical trial, we usually say that negative results are not reported, but here it is reported, probably because it's a very important question to be answered for the clinician. And second is that instead of just one outcome, they have gone for a score, which is understandable because you have multiple outcomes like death, you have hospitalization, complications, worsening of heart failure. So how do you get everything into one outcome? That's a very challenging issue for the statisticians also. And I think they have done it very cleverly by converting it into a kind of a category score. So these are the 2 points which I want to make. Otherwise, both the people, the Dr. Gautham who presented and also Dr. Meena who looked at it critically, they have done a good job. They have gone into the details, going by the consort guidelines and all that. Otherwise, I don't have many things to say for the design part. Of course, the sample size calculation has not been mentioned, but I can understand that because heart failure is a rare event in children, and if you arrive at a big sample size, you may not be able to get the number of subjects in your study. So you go with whatever you have. So I think that is understandable, and they did achieve a very reasonable number. So I think you can believe that these drugs are reasonably equivalent in terms of their efficacy. But now, of course, the question is, which should you prefer? So probably you have to choose by looking at the side effects for one thing, and second by looking at the cost. Of course, especially in a country like India, that might turn out to be very important. So these are all the only comments I have to make. So if anybody has any question on the design statistics part, I'll be happy to answer. Otherwise, I may be permitted to leave. Just one more thing I just want to mention, because this came in circulation. Some of you might know that Dr. Ramachandran Vasan I think he's still on the editorial board. I don't know if still is on the editorial board. He used to be for a long time. Vasan used to be faculty at the Children's Center for some time, but then he left for Boston. He is a professor at Boston University. So, I mean, just for information which people might be interested in.
Regarding the sample size,
yeah, please. Please, sir.
I had a question. So the sample size, does it change if it is a superiority versus a non-inferiority or an equivalence?
What is that?
The sample size, does it change if it was a non-inferiority trial, let's say, the same trial, sample size would it have been higher or lower? If it was a non-inferiority
I have to
trial.
check, but my gut feeling is that if it's a non-inferiority, you probably need a larger sample.
Larger.
Yeah.
Okay.
Dr. Pathanabhi, sir? The forum is open for discussion. Ramankutty sir will be leaving as soon as possible. So if anybody has anything to discuss, kindly discuss. Yes, sir. Please, sir.
I have nothing much to add. I was just a listener because the topic is the drug as I never used. And nowadays, a general pediatrician doesn't treat complicated heart failure by himself. Other than enalapril, we have never used a receptor blockage has never been used in childhood pediatrics. I have not seen any pediatric cardiologists also using it, probably because I was not dealing with complicated heart failure patients. Cardiomyopathy, yes, very often we had seen in our practice, but not anything more than that. Anyway, very good study, very good analysis. That's it. Thank you.
Thank you, sir. Ramankutty sir, we had Dr. Lakshmi Madam, HOD, SIT Hospital Pediatrics, Pediatric Cardiology Department. Dr. Lakshmi Madam, any comments, Madam? Lakshmi Madam? Yeah.
Actually, we have recently started using sacubitril valsartan in heart failure patients. And maybe last 1 to 2 years, we are using sacubitril valsartan in selected patients with systolic dysfunction of left ventricle. And I don't know, I am used to more comfortable with NVAS, AC inhibitor. I am yet to, there is no definite evidence from our side to say this is using sacubitril valsartan has a added advantage. I don't know. I am more comfortable with using AC inhibitor.
Okay, madam. Sir, as Ramankutty sir was telling, any comment on the economic constraints of this drug, sir? Is it available? Is it very expensive, Harikrishnan, sir?
It is freely available, but definitely it is more expensive compared to enalapril. But it is available in the adult population for quite some time. So now that patent rights have gone, so now the prices have started dropping, but still compared to enalapril, it is significantly higher.
Dr. Meena was showing one slide with the number of deaths less in enalapril arm. Am I right or so? Dr. Meena? I mean, the question I wanted to ask was that, sir, Ramankutty sir, if both has got, I mean, there is no difference in use both of them, and at the same time, this parent predictor issues and all those things are better in this sacubitril part. So, is that indirectly saying that it is safe to use and we can start using sacubitril valsartan, sir?
Yeah, that is what I would say. But then, as Dr. Harikrishnan says, enalapril is cheaper and it is equally effective. Why not use it in our population? I don't know. I mean, that is probably, and also you have to consider the pediatric population. The route of administration might be an important factor. I don't know if there are pediatric. I mean, all these. I'm not very sure about those aspects. I have been a long time from treating children, so I'm sorry.
So these are available as granules also, which can be diluted. So I mean, though it is not available in India, that formulation, but it is for the study that used that.
Okay.
Any more questions?
That's, I think, very few, because and that's kind of very few number difference may not, it may be just by chance. So that is what we mean by statistically not significant, it cannot be attributed. I mean, it can be attributed to chance. So don't worry too much about that aspect.
I think there are no statistical questions as far as I am concerned. The forum is open for discussion.
I think
If
I
any
had to
queries
leave.
are there. Okay, sir. Thank you, sir. Thank you for your comments.
Dr. Vijay Margar.
Sir,
Hello.
please, sir. Please, sir. Good evening, sir.
Yeah,
Yes,
good
sir.
evening. To Dr. Harikrishnan, is there any age cutoff for using ARBs? You can use in newborns also.
ARBs, we exercise some caution in using, sir. I mean, in our practice, we usually don't start in the newborn. ARBs or AC inhibitors, both. And even in this trial, it is 1 month to 18 years, the inclusion.
And when we are using the BNB, all these things along with the diuretics, will it affects any electrolyte problems? Because we are using natriuretic peptide inhibitors, so
Natriuretic
lot of
peptides with diuretics. No, sir. We have in adult, there is enough data to say that it does not cause any significant change in the way NT-proBNP is measured, nor does it cause any change in sodium or other electrolytes.
Okay, thank you.
Harish sir, I'm sorry for asking. I have this doubt that it can be used. It is usually used in acute cardiac failure or in long-term management of. I mean, can it be used in long-term management, or should it have to be like that only, sir? What is the protocol
So
like?
currently it is used for chronic heart failure, but there are studies in adults in acute heart failure also. But it should be used with caution because acute heart failure means most of them may be in pulmonary edema. Their BP may be actually on the lower side. So starting vasodilator in the acute setting may not be desirable. But yeah, most of the studies are in chronic heart failure, and we tend to stop all the inotropes. And once you decide on oral therapy, then only we start ARNI or AC inhibitors.
Yes, sir. And could you add a word on this? I mean, there was a low. I mean, what do you call that? The ejection fraction, there are two types. That is what I understand from, because this is used in the reduced ejection fraction group and all. So could you throw a light on that part, sir? Actually, is there a heart failure with the
adults,
ejection fraction?
Yeah,
No,
adults,
sir. This
we classify
study,
it as
sir.
the study. Yeah? You need a clarification regarding that
study,
reduced ejection fraction.
Yes, sir. Yes, sir. Yes, sir. Because is there a another concept? Yeah, another thing with which is high ejection fraction, cardiac failure in children also. I mean, why this is used in reduced ejection fraction? Which are the conditions which result in reduced ejection fraction cardiac failure? A few sentences
So
on
failure
that.
with reduced ejection fraction means that the ejection fraction, the LV dysfunction, is the cause for heart failure. So there again, compared to a normal ejection fraction, that is, if you take 60% as a normal ejection fraction in adults, less than 35% is considered severe LV dysfunction.
Okay.
So beyond 35, that is 35 to 60.
In every heart failure, we expect in every heart failure we expect a reduced rejection fraction only, no? Because a heart failure cannot be
so that is what,
a heart failure with the yes.
So heart
I mean,
failure
then why
can
are they
be
specifically
because of
telling that this is
heart failure means that heart is not able to meet the metabolic requirements of the body. So it does not mean that even if the ejection fraction is normal, if the heart's diastolic function is impaired, heart is not able to get enough blood, like in hypertrophic cardiomyopathy or restrictive cardiomyopathy. They'll also present with features of heart failure. They'll also present with pulmonary venous congestion. That is also heart failure. So even when heart failure is normal or slightly less than normal, like 50 to 60%, then also they can present with heart failure. So that is why the concept of preserved ejection fraction, heart failure with preserved ejection fraction.
Okay, that's
and the rest in between is called mid-range ejection fraction or mildly reduced ejection fraction, 40 to 50. So you
So
necessarily,
yes, sir. Yes,
no,
sir.
it is not
Please
necessary to
continue, sir.
have low ejection fraction in heart failure.
Yeah, I got it, sir. And any other centers you already started using this Cibutril valsartan
Yeah.
in
This
India? I mean,
after
in Kerala.
the approval, I mean, this has been FDA approved after this trial.
Yes, yes, sir.
It was approved in adults a little long time, like 2019-20, it was approved in adults.
Yes, sir.
So it was approved in children in 2024,
Yes, sir.
and there are a lot of centers who use the drug.
Use it under. Okay. I think there are no other questions from myself. If any other questions, the forum is open for discussion.
Very few
Vijaykumar sir,
participants.
anything more to add, sir? Yeah, sir, it is a usual phenomenon. Maybe the postgraduates are usually in duty and all those things and that. I think after live streaming, the number of views usually goes up actually. Maybe they will get time. When they get time, they watch this and things like that. And this is a novel drug as far as pediatrics is concerned, and there is a likelihood chance that it can come as a short note, don't know. In recent years in DependB or MD examination, we don't know. So we wanted the credit of having presenting this in the journal club also. That is why that is another reason for, this paper was selected by Harikrishnan sir only, and with the Lakshmi Madam's approval, we try very hard to get more audience, sir, actually. And sometimes the topic is also important. Sometimes the topic will be very deep, and sometimes it will be very, useful for the PGs as well as the pediatricians also. Sometimes nutrition, sometimes things like sacubitril. Usually 10 to 20 patients, audience will be there, but sometimes it will be like this only. But thankfully, the views are the thing which is a inspiration. And thanks for attending, Vijay Kumar sir. Anything more to add, sir? Vijay Kumar sir? Any comments? Okay, I think there are no more comments or for discussion on that. Harish sir, can we call it a day? Can we try to position?
Everybody is viewing this one afterwards. Live stream, they are not. You are getting that recorded version. They are seeing that one according to their convenience, and you can see the hit. And most of them are preparing for examination or duties. So don't stop it. There are people who are getting benefits. Okay.
That is a great words of inspiration, sir. Even though you told that to console us, it is a great word for inspiration, sir. And we have a very special guest today, Dr. Bindu GS madam with us. Madam, please, madam. It is very rare to see madam also in. Bindu madam, we just finished discussing this. And
actually, when you are having pulmonary problems, pulmonary arterial pressure is high, the BNP can be raised,
Yes, BNP can be raised in many other conditions also, like pulmonary embolism, sepsis. Also, it can be raised.
When we are going for younger age group, all these factors should be excluded when you are including in the study. Exclusion criteria.
But
exclusion
when you
criteria
have
is a bit,
low ejection
less
fraction,
lengthy, right?
When you have a low ejection fraction, you can assume it to be due to the heart failure itself, the NT-proBNP rise.
And there can be variation in preterm and term babies.
Oh yes, that is also documented. The changes in proBNP over time.
So the exclusion criteria should be a bit more, expensive and elaborate. That is what is that what Harish sir?
Exclusion
Because they
criteria,
have
I think
excluded
inclusion.
a few.
I think inclusion itself, they've very specifically mentioned it is less than 45%. So most of the other conditions would be out.
Will be excluded.
Even with the sepsis, you can have no intrauterine infection, myocarditis.
That is possible. So that's what. So myocarditis they've included, which
But
is
that can be due to intrauterine infection also.
So that is what that less than 1 month. 1 month they've excluded, probably to exclude those sepsis, intrauterine infection, and those kind of things.
There was one question in the chat box, sir, regarding the digoxin importance in cardiac failure, but now it has disappeared, I think. I cannot see it. Dr. Harikrishnan, sir, can you see the question?
Yeah, digoxin has a very important role in systolic heart failure, like this article which is discussing systolic heart failure, low ejection fraction causing heart failure. Digoxin definitely has a role because it is an oral inotrope. It is like giving an inotrope. Can be given orally. So it definitely has a role. Only thing, we usually don't monitor its levels. So the likelihood of side effects due to its high levels is increased. That is why most of the studies of digoxin in adult population or in pediatric population has not shown any benefit. And in fact, some of them have shown that it is harmful. But it has a very important role in systolic heart failure. It does not have any role in, let's say, a VSD with heart failure. So there is no systolic dysfunction. So in those conditions, there is no role for digoxin. However, like in LV dysfunction, systolic heart failure, it definitely has a role, and that is one of the comments that Meena was trying to make. That digoxin in the trial mentioned, it is only 30% use in this trial in the world over, whereas in our population, if you take, it is much higher. The use of digoxin in systolic heart failure will be probably around 60%. Madam, any comments? Vijay Kumar sir, any comments on?
No, sir. No.
Yeah. Madam was telling, sir, Lakshmi madam.
No, actually, digoxin, systolic dysfunction, we usually use digoxin. But as Harry said, we have to be cautious about the digoxin toxicity, which is more common in younger children. Previously, we used to use digoxin for all LV systolic dysfunction, but nowadays the usage has come down, but still we are using.
Okay, madam. Thanks, madam. Vijay Kumar, sir? Sir was...
Okay.
Okay.
No, nothing to add.
Okay. Shall we end the session, sir?
Okay.
Harikrishnan, sir.
Yes.
With
Yes.
Lakshmi madam,
Both Gautham and Meena had presented very well.
Thank you, sir. Thank you.
Thank you so much.
Yeah, I think Dr. Srijit has left the session. So, for the sake of IAP Thiruvananthapuram, I would like to congratulate Dr. Harikrishnan sir, Dr. Gautham, and Dr. Meena, and thank Dr. Lakshmi madam, Dr. Ramankutty sir, Dr. Padmanabhan sir, Dr. Vijay Kumar sir, and of course Dr. Harikrishnan sir. Thank you, sir, for the help that sir has given. Sir has selected a very good article, and this article is very beautiful in the sense that it discusses a lot of things as far as a student interested would like to know. And sir has mentored also the PGs very well. So congratulations and thanks to Dr. Harikrishnan sir. And once again, thanks to all who have participated in the session. And it was an excellent academic feast, no doubt. And thanks to IAP Thiruvananthapuram, Dr. Srijit sir, Secretary, Dr. Kalpana madam. Kalpana madam was there, madam left actually, and Dr. Bidduji's madam also. And wishing you all a great time ahead. Good night. Take care. Till next session. Thanks once again. Thank you, sir. Bye.
Thank you.
Thank you, Vijay Kumar sir. Thank you, Harikrishnan sir.